Hey, sweetie, what's going on? I already fed you. You just want to cuddle? That's cool. Okay. I wasn't trying to make it that big. There we go. I'm not sure why it does that, but I got all the coins. I guess this outfit's good. I'm gonna change your hair. Oh, that's cute. Yeah, we'll do that one. And we'll just do ginger pear. Ooh. All right, let's do it. Okay, so this chapter is about tricuspid stenosis, and I mean, that's pretty much, I mean, I guess it probably goes into regurgitation as well. Patient presents with a history of rheumatic heart disease and diastolic rumble that varies with respiration and has an opening snap. What's the most likely diagnosis? History of rheumatic heart disease. It's a valvular issue for sure. I mean, most likely. And then you've got diastolic rumble. So it's going to be a semilunar valve. Varies with respiration. That's going to be the pulmonic stenosis. Let's take a look. I mean, it says it's tricuspid stenosis, and I don't know why I'm surprised, but that for sure that sounds like pulmonic. So what we're going to do is see what the difference between tricuspid and pulmonic is. Pulmonic stenosis is a harsh systolic ejection. Okay, so pulmonic regurgitation. Low-pitched diastolic murmur increases with inspiration. So the difference is the opening snap, it looks like. When you've got severe pulmonic regurgitation, it's high-pitched rather than low-pitched. Okay. All right, so it's the opening snap that makes the difference between the tricuspid stenosis and the pulmonic insufficiency. Tricuspid stenosis is almost always an isolated disease. Now, I don't know what the book says, but I'm sure that's not true. Let's see. Rarely alone. Yeah. If you have tricuspid stenosis, it's very likely that you have calcification on the other valves as well. Just how it works. TVA is 220 overpressure half-time. Well, that's mitral. Is that also tricuspid? Maybe related to Epstein anomaly. Carcinoid heart disease. Here we go, Doppler. 190 divided by the pressure half-time. Makes sense. I'm just going to put the correct answer in here for when I review it later. Okay. Group chat is lighting up. Everybody's doing homework right now, I think. Okay. If the Doppler exam reveals TVA that's 1 centimeter squared, that's already severe. Pressure half-time equals 200 milliseconds, and the pressure gradient is 8 millimeters of mercury. Patient most likely has mild tricuspid stenosis. Now, I don't think that's true just because 1 square centimeter is too small. I know that for sure. So let's take a look. Yep. The tricuspid valve area less than or equal to 1 square centimeter is severe just already, because that's not enough room for the blood to flow through. Pressure gradient greater than or equal to 5, and our pressure gradient is 8. And our pressure half-time of greater than or equal to 190, and we've got 200, so this is all severe. And I'm just gonna highlight that severity scale for when I'm flipping through studying later. Tricuspid regurgitation creates a holistic systolic murmur that decreases with respiration. I think it increases with respiration. Yep, it increases with respiration. But it is a holosystolic murmur, which means it is throughout systole. I do have a question whether or not that includes the contraction and relaxation time. Isovolumic. It doesn't look like it says. Ah, here we go. On our Doppler, that is very small. All right, well, let's take a look at our EKG on this little picture over here. Maybe that'll help us. It doesn't look like it includes that. I'll have to ask tomorrow. Oh, geez, oh, Pete's. Oh my gosh, this coming week is gonna get crazy. This last week was crazy. I don't know why in my mind I thought this coming week was gonna be a little bit calmer. Not the case. Okay. I need to update my calendar with a bunch of different stuff that I forgot about. Okay. Whoa. My heart rate shot up during that. That's fun. Okay. Significant tricuspid regurgitation may lead to enlargement of the right atrium, right ventricle, or inferior vena cava, hepatic vein, superior vena cava, and neck veins. That sounds true. The only one I'm not sure about is the right ventricle, because that's going to thicken up, but getting bigger, I'm not sure. Maybe with time. Myxomas, endocardiac wire, vegetation, tumor, papillary muscle dysfunction, ruptured chordae, flail, rheumatic TR, prolapse, carcinoid heart disease, congenital tricuspid regurgitation, other than Epstein's anomaly, prosthetic valve dysfunction, complications. Here we go. Enlargement of right heart. Okay, so that includes both the atrium and the ventricle then. Leads to AFib, IVC, hepatic veins, SCC, neck veins. Yeah. What percentage of tricuspid valve prolapse is seen in... Oh, what is that? What is that word? I'm too old. Concomitant. That's a new word. What is that? Let's Google it. Why have I not seen this before? Am I just crazy? Concomitantly is at the same time. Really? Concurrent is also a word that people use. Concomitant? Is that a specific medical term that I've just never come in contact with? Occurring or existing at the same time as something else in medicine. Okay, all right. Well, you know what? We're going to take this opportunity to expand our vocabulary. Oh boy. Concomitantly. Medical word for simultaneous. I know a lot of words that mean at the same time, but I've never heard that one. Or maybe I've heard it and I just didn't know what I was hearing. Okay. What percentage of tricuspid valve prolapse is seen with concomitant mitral valve prolapse and is diagnosed with excessive billowing, 1, 2, or 3 tricuspid leaflets into the right atrium? Probably pretty high percentage, I would think. Concomitant ailments are quite common. Let's see. That's all Doppler. Continuous flow, Doppler, severity scales. Coadaptations. If it's asking me for a specific percentage, then it should be in here exactly as it is. That's just how these workbooks are, which is great. But okay, we'll just read a whole section and see if we're maybe just missing it. Oh, okay, there we go. It's in this section, which I'll just read. Okay. Tricuspid regurgitation is the result of an incompetent tricuspid valve that permits backward systolic flow from the right ventricle through the closed tricuspid valve back into the RA. The murmur that it creates is a hollow systolic murmur that increases with inspiration. Causes. There are a variety of etiologies that result in incomplete coadaptation and improper opposition. Apposition? Apposition, not opposition. There are a variety. Trace to mild tricuspid regurgitation is considered within normal limits and present in the majority of patients. I've got minor tricuspid and mitral valve regurgitation. I don't know about the other valves. I don't think I have anything with the pulmonic or the aortic. Most common cause of tricuspid regurgitation is secondary or functional tricuspid regurgitation caused by annular dilation, usually related to right heart enlargement associated with left heart disease, right ventricular dysfunction, and pulmonary hypertension. Primary tricuspid regurgitation is caused by myxomatous degeneration, which myxoma is a cardiac tumor, intracardiac wire for a pacemaker, i.e. vegetation. So if you have a bacterial infection, you can get growths on your valves, similar looking to moss in a stream attaching to rocks. Tumor, mass, or clot, papillary muscle dysfunction, ruptured chordae flailing leaflet, closed chest trauma, or biopsy. Rheumatic tricuspid regurgitation is associated with rheumatic tricuspid stenosis, or leaflet thickening, scarring, calcification, fusion, chordae tendineae to commissures. Rheumatic heart disease is what happens if you have strep too often or for too long. You end up with permanent cardiac damage. So if you have strep throat, throw away your toothbrush after you start your antibiotics. Make sure you get antibiotics, because otherwise it could destroy your heart. So that's a thing. If you can't afford to buy a new toothbrush, boil it. Tricuspid valve prolapse is seen in 20% of cases with concomitant mitral valve prolapse and is diagnosed with excessive billowing of 1, 2, or 3 tricuspid valve leaflets into the RA. TVP is classified as mid to late systolic or hollow systolic, same as MVP. So our answer is 20%. But we're just going to read the rest of this for completion's sake. Carcinoid heart disease with tricuspid valve involvement leaflets are thickened rigid with no change in position from diastole to systole. Tricuspid stenosis, tricuspid regurgitation, pulmonary stenosis, and pulmonary regurgitation are all possible. Congenital tricuspid regurgitation, rule out Epstein anomaly or other. Prosthetic valve dysfunction. For treatment options, TR is usually a secondary problem, annuloplasty if necessary, and TVR if necessary, a replacement. Possible enlargement of right heart leads to AFib, IVC, hepatic veins, SVC, neck veins. Yeah, okay, we went through all this before. During the echo, do you detect rigid tricuspid valve leaflets with no change in position from diastole to systole? What is the most likely diagnosis? That sounds like carcinoid heart disease, which we just went over. Thick and rigid with no change. When determining tricuspid regurgitation severity, we must consider presence of right ventricular volume overload pattern in the size of the right heart. Sounds true. Let's see. Here we go. Right ventricular valvular obstruction pattern, RVVO, which is I don't know quite how to explain it. Right ventricular dilation with paradoxical septal motion. There you go. Always consider the size of the right heart. It is unusual to see normal right heart chamber volumes with chronic or severe TR. Volume overload. Volume overload. VVL, volume overload. True. Alright, we only got a couple more for this. That's nice. Assume peak tricuspid regurgitation equals 3 meters per second and central venous pressure is 14 millimeters of mercury. What's the right ventricular systolic pressure? So we've got 3, we got 14. Shoot. Peak velocity is 3. Okay. Okay, yeah, there's math involved. That's what I figured. I could not for the life of me remember what formula it is for this, but is it the Bernoulli? Mm-hmm. 4 times the velocity squared. Plus the RAP. Okay, so 3 times 3 is 9, times 4 is 36, plus 14, so it's 50. I need to memorize that. All right, pulmonary hypertension is caused by another disease such as lung disease, diastolic heart failure, or left heart failure. Sounds true. I accidentally already went through this, so that's good. Yeah, it is. Great. All right. ECHO provides a non-invasive assessment of pulmonary hypertension and accurate systolic pulmonary artery pressure. I think that's true as well. Non-invasive. Strong correlation. Systolic pulmonary artery pressure equals the right ventricular systolic pressure. Identify the echo finding that supports pulmonary hypertension. Diastolic dysfunction, patent foramen ovale on bubble study, which means there's a hole in the heart. Ventricular septal flattening, which is when the ventricle during systole compresses because of the pressure in the right ventricle. So the left ventricle looks like a D if you cut it in half. So all of the above. Sounds good. All right, great. So I think that's it for this homework. Yay. Oh, big stretch. Okay, let's see. Oh, that's good. I'm not entirely sure. Let's go ahead and pause this and play with our fish for a second as a reward. Yay. Okay, let's see. Let's go ahead and put this. Let's go ahead and upload this here real quick. And as we do it, we're going to review it, because that's how we learn. All right. Patient presents with history of rheumatic heart disease and diastolic rumble that varies with respiration and has an opening snap. What's the most likely diagnosis? And that's going to be tricuspid stenosis because of the snap. Tricuspid stenosis is almost always an isolated disease. That is false. TVA 220 divided by pressure half time, that's going to be 190 divided by pressure half time, so that's false. The Doppler exam reveals tricuspid area of equal to 1 centimeter squared. Okay, it goes on. All of this is severe, and this says mild, so that is false. Tricuspid regurgitation creates a holistic murmur that decreases with respiration. That is false. It increases with respiration. Significant tricuspid regurgitation may lead to enlargement of the right atrium, right ventricle, inferior vena cava, hepatic veins, superior vena cava, and neck veins. I'm going to say that is true. What percentage of tricuspid valve prolapse patients also have mitral valve prolapse? And that's 20%. They changed the wording in here. That's cool. Okay. During the echo, you detect thick, rigid tricuspid valve leaflets with no change in position from diastole to systole. That's carcinoid heart disease. When determining tricuspid regurgitation severity, we must consider the presence of a right ventricular volume overload in the size of the right heart. It's true. RVBO. Assume peak tricuspid regurgitation velocity is 3 meters per second and the central venous pressure is 14 millimeters of mercury. What's the R at VSP? So that's 3 squared, which is 9, times 4, which is 36, plus 14 for our pressure, so that's going to be 50. Pulmonary hypertension is caused by another disease such as lung diastolic heart failure, left heart disease. That's true. Echo provides non-invasive assessment of pulmonary hypertension and an accurate systolic pulmonary artery pressure. That is also true. And our last question, identify the echo finding that supports pulmonary hypertension, and that's all of the above. Diastolic dysfunction, patent foramen ovale on bubble study, ventricular septal flattening. All right, let's see what we got. 100%. Fantastic. Good, good, good. Definitely need that in this class. Okay, so let's see. We got a book check-in tomorrow. Let's see. We've got a Kahoot and a quizzes. Core pulmonary, which I need to look through. Okay. I'll do the book check-in thing last, because I'm pretty well done with that already. take a look for our other classes. What do we have to do for tomorrow? For lab, I have to submit my reflection, which I will do later. Cardiac procedures, homework, week 4 is due. Let's see what that looks like. I am very happy that I got a 90 on that exam on Thursday. That was pretty nice. Pretty good. All right, let's see. Oh, good Lord. We've got so much. There's so much. Okay. I was really not... Oh, I really didn't think there was going to be so much. Okay, all right, this is fine. God bless it. Okay, so what I'm probably going to do with this is I'll see if I can do the workbook stuff. Auto workbook as well. I need to take a look through. God bless it. Okay. 148 through 160. Yeah, there's those pressures. Cardiac catheterization. And that is 148 through 160. I'm going to be so honest right now. During this lecture, it was rough. So I think what I'm probably going to do is just read all of this out loud and record it so that I can listen to it later. Oh, man. Oh, you know what? I also should make a new recording of the full protocol too. Wonder how much of that I can remember. I heard somewhere that doing live streams actually lowers your IQ temporarily. I don't know if that's true, but I can totally see it being accurate. Just simply because like you're multitasking, you know. God bless. That was a lot. That was a lot. All right. Okay. "42 pages, 48 pages of reading, and looks like 45 questions. Cool. Okay, page 50. Okay, 54, 55. Okay, so that's 41 through 50. Okay. Okay. If nothing else, at least I know what is necessary to finish before Thursday. We're in person Thursday again. Okay. I don't know if you want to see this cool thing or not. You probably do. Let's see if I can pop this up there. CG 130, yeah. Okay. All right. This is the Wiggers diagram. Which hopefully you'll find interesting. Make this a little bit smaller. Yeah, I guess that's fine. Okay. So that is what the questions that I'm about to tackle are. Like, this is a pretty important part of it. This is a lot of information, but yeah, now you have access to it. This is a pretty cool visual representation of the pressures and electric currents in your heart. And I am not going to explain all of them, but we're going to go through the homework. So by the end of this, you should probably understand a lot more of it if you want to. Maybe. It's hard. Maybe I'll understand it too. Okay. Intro to cardiac catheterization. Ugh. During the cath procedure, the cardiologist inserts a catheter in the patient's artery or vein, and then the catheter is threaded into the heart. That is true. But I should probably highlight where it is in the text too for study purposes. So let's take a look. Okay, cardiac catheterization. Study of the heart with a catheter inserted in artery or vein in arm, neck, or groin. Once inserted, carefully threaded into the left or right heart. Apparently, there are some procedures now that that actually make a hole in your interatrial septum if they're going one place or the other and they can't find a good vein or artery to get to that side of the heart. They cross over, which is interesting, because if they did that 20 years ago, they'd probably do so much damage that whatever they were trying to improve probably wouldn't have, like, the gain would not have been worth the damage. But now they can do that, and it's worth it, and that's pretty neat. Okay. Most popular approach to left heart cath. Pigtail catheter, percutaneous through the femoral artery, is the most popular. Okay, and that is the femoral artery, not the femoral vein. That is important. Choose the catheter frequently utilized for the left heart cath. I think we covered that. That's the pigtail. Okay. Catheter frequently utilized for right heart cath via femoral vein. That is the Swan-Ganz catheter. And you know what? I think I'm going to color code these. So the left heart is getting pink. Pigtail, femoral artery. And the right heart gets the Swan-Ganz. Femoral vein. Okay. What procedure involves passing the catheter from the right atrium through the interatrial septum? That's what I was talking about before. Into the left atrium. Transseptal. Oh, that is important too. Transseptal. Now, it may be interatrial septum, but is the transseptal, not the transatrial. Transseptal approach. Transseptal approach. Valvular heart disease is an indication for cardiac cath. Yep. Today, most labs store digital computerized images known as cine. I think they're going away from the cine. Filming methods include cineangiograph or cine. Cine stores movies on 35mm X-ray film or digital computerized images. Cineless, used in most labs today, so we're not using those X-ray 35mm X-ray films as much as the Cineless. Okay. Cineless. Fluoroscopy is an X-ray technique with a screen that provides immediate visualization inside the body. That is true. Oh shoot, we're not getting study credit. we're deep in it. Let's get some rum. Neat dark rum in triplicate. Oak, caramel, cocoa riding slow, powerful wave. That sounds nice. What is that fruit? All right. O2 saturation can be calculated via the indicator dilution technique, thermodilution method, Flick method, or angiographic technique. Oh my god. Okay. Well. Looks like I'm going to have to read another section. All right, so collect blood samples to measure O2 saturation. Evaluate a shunt. Calculate cardiac output. Oh, I feel like I missed something because that seems... Oh, okay. So you evaluate the shunt by evaluating the O2 levels and changes in that. So detect a shunt through evaluation of O2 saturation changes. Calculate the shunt size based on the difference between the pulmonary flow, QP, and the systemic flow, QS, via the QP divided by QS ratio. Prepare the shunt with a special catheter that is able to deploy a patch across the atrial septal defect. Calculate the cardiac output via the indicator dilution technique, Flick method, thermodilution method, and angiographic technique. Okay, so that's not O2 saturation. That's going to be cardiac output via these techniques. Okay. The pressure distal. Move this over here a little bit. I feel like you're sitting behind me. Okay. Pressure distal to the pulmonary capillary wedge is the approximate right atrial pressure, and the pressure recorded when the balloon is deflated equals the pulmonary artery pressure. Okay, so that relates to G. Acquire the left atrial pressure, the LAP, during the right heart cath via the pulmonary capillary wedge pressure, the PCWP, or transeptal approach. Obtain the PCWP when a flow-directed balloon tip catheter, the Swan-Ganz or right heart catheter, is passed from the right ventricle into the pulmonary artery and allowed to float as far as it will go until it is wedged in a pulmonary end artery. Pressure distal to the wedge, which is after, is approximate left atrial pressure. The pressure recorded when the balloon is deflated equals the pulmonary artery pressure. So what this says here is the pressure distal to the pulmonary capillary wedge is approximate to the right atrial pressure, but that's not true. That is the left atrial pressure. And the pressure recorded when the balloon is deflated equals the pulmonary artery pressure. So that's true. Okay, but this is false because it's the LAP, not the RAP. Choose the right heart catheter intervention. Okay, so the right heart catheter intervention. Got left heart cath, left ventricular angiogram. I think that's going to be okay. Oxygen saturation level, pulmonary angiograph, pulmonary capillary wedge pressure, or all of the above. Okay, so the saturation level is for sure. Capillary wedge pressure is what we just covered, so yes. Angiograph, that's a left ventricular one, I think. But it might also be a right. So let's take a look and see if we've got an angiograph on the right. So we've got O2, evaluate a shunt, cardiac output. Oh, here we go, angiographic technique. Okay, so all of the above then. Pulmonary angiography is used to diagnose a pulmonary embolism. True or false? Yep, that is true. Okay. During the cath procedure, one can detect a shunt, calculate shunt size, and sometimes treat with a patch. That is true. Which of the following does left ventricular angiogram assess? It is right here. It evaluates left ventricular function, global, and segmental wall motion. Cardiac output, endomyocardial biopsy, left ventricular function, or right ventricular function. So that's going to be left function. What intervention involves injecting radiocontrast agent directly into the structure so it becomes temporarily visible on X-ray? Fluoroscopy is not an option. Angiogram, angioplasty, angio recording, atherectomy. Ectomy is removing a thing. Plasty is adding a thing. Gram or recording, I think it's going to be gram. During an angiogram, radioactive contrast agent. Yeah, there we go. It's amazing what you can figure out just by knowing the medical terminology. Delicious. Okay, left ventricular ejection fraction is computed in the cath lab via area length method or eyeballing it. Yep. What happens when plaque buildup inside the lumen of a coronary artery. I'm going to say occlusion. Coronary angiogram assesses coronary arteries for CAD, which is coronary artery disease. Catheters injected in the opening. Where's our info that we need for this? Plaque buildup in the lumen. There we go. Plaque builds up inside the wall of the coronary artery. It causes an occlusion. An occlusion presents as a disruption or narrowing. The occlusion can be quantified as 90% occlusion of the acute marginal artery. Over time, the plaque causes narrowing of the artery and the artery hardens into arteriosclerosis. Plaque is present. The cardiologist determines the best method of treatment. One option is coronary artery bypass grafting, which is CABG, which most people have heard of to some degree. Cardiothoracic surgeon performs a CABG via open heart surgery, although in some cases a mini thoracotomy is utilized. All right, so I'm not sure if it wants me to pick occlusion here. Pretty sure it does. All right, we'll just do occlusion because I'm pretty sure that's correct. I don't know if that's exactly what they want, but I think it is. All right, coronary angiogram is one of the most popular studies in the cath lab. I think that's probably true. Yes, it is. Coronary angiogram assesses the coronary arteries for CAD and is one of the most popular studies performed in the cath lab. Not all blockages require coronary artery bypass graft surgery, or CABG. Some are treated in the cath lab. I think that is true. There are also cath lab treatment modalities such as angioplasty, which is percutaneous transluminal coronary angioplasty, which means a catheter with a small balloon is placed in the lumen of a coronary artery, and then the balloon's inflated and the pressure presses the plaque against the wall of the artery. Stenting, which is an expandable wire tube, and an atherectomy, which is a tiny little slicey wheel that goes through the coronary arteries and chops up all of the blockage and sucks it out with a little vacuum. which sounds, personally, that sounds very scary to me. I mean, it's one of those things where if you want that one specifically, like if the cardiologist wants that one, they have a very good reason for it. Just like all of this stuff. There's never just, oh, this isn't like a whim situation. They do a lot of tests before they do stuff like this. Make sure it's the right choice for everybody. Still makes me a little nervous sometimes, some of this stuff, you know. I think whirling blades just in general seem like a precarious thing. Okay. Choose the intervention that utilizes catheter equipped with a balloon that inflates and presses the plaque against it. I'm trying not to look. Percutaneous transluminal coronary angioplasty, maybe? Yep. Angioplasty. Lovely. After the plaque is pressed against the wall of the artery, what is inserted into the artery to reduce the risk of reclosure? Stent. Choose the intervention that utilizes a catheter equipped with a cutting device and a whirling blade. I think that was the ectomy, the atherectomy. Yeah. Intravascular ultrasound utilizes a coronary artery catheter equipped with a miniature ultrasound transducer that acquires images of coronary lumina and walls and outlines of blood flow through the lumina. That sounds true, but we're going to read it because sometimes they change a word. Intravascular ultrasound, or IVUS, performed with a coronary artery catheter equipped with a miniature ultrasound transducer. Catheter enters the coronary lumen and images of the coronary lumina and walls are acquired. IVUS can also outline blood flow. This technique is becoming more popular and may be performed in conjunction with the coronary angiogram. Or true. Cath pressure tracings are acquired from the chambers and peak pressures are compared, known as instantaneous maximum mean peak to peak. I think that's mean. Oh, here we go. Pressure gradients. Peak to peak pressure gradient. Pressure tracings are acquired directly from the chambers and peak pressures from each chamber are compared. And mean, or average, transvalvular gradient. Mean pressure gradient. All right. So this right here, cath pressure tracings are acquired from the chambers and peak pressures are compared, known as peak to peak. Mean pressure gradient derived from the echo lab correlates best with cath mean pressure gradient. We want both. So these three pictures here, which I know you can't see very well, sorry. This is what I'm working with. So these are the specific measurements from that larger diagram that I've got sitting right there. We're kind of zoomed in on those specifically. Okay. Okay, you can't see when my mouse goes behind that, otherwise I'd point to it for you. So cute. Okay. Mean pressure gradient provides the average derived from all of the velocities within the flow between two chambers. True. So we're calculating the maximum pressure gradient and the mean pressure gradient for these. And let me see if I'm not able to show you on here where exactly we're talking about, but we are looking at the blue line, and we're looking at the red line. That's what we're looking at right now. And we're looking at that gap, that crescent shape in between. Oh, hey, technician. Well, happy to have you. I hope your chores are going well. Okay. Mean pressure gradient provides an average derived from all of the velocities within the flow between the two chambers. And in the book, we have mean pressure gradient provides an average pressure gradient derived from all of the velocities within the flow between the two chambers. So, true. Doppler echo provides the peak instantaneous pressure gradient, or the peak gradient between the two chambers at the same instant in the cardiac cycle. Okay. And max PG, max pressure gradient, provides peak instantaneous pressure gradient, and it is the highest gradient between two chambers at the same time in the cardiac cycle, either systole or diastole, and is always greater than peak to peak. Okay. Cath determines presence, severity, and etiology of regurgitant valve. I can't talk anymore. Okay. That is true. All right, what procedure identifies aortic regurgitation when contrast leaks from the aorta back into the left ventricle? Okay. Present severity and etiology of the regurgitant valve is determined with aortography, contrast injected into the aorta, or ventriculography, contrast injected into the ventricle. So this one's going to be aortography. With acute mitral regurgitation, the left atrium does not have time to compensate for the additional flow. So what is resulted? All right, so acute mitral regurgitation, the left atrium does not have time to compensate for the additional flow. So that is going to result in left atrial pressure elevation. Increase in left atrial pressure. That sounds right. Okay, during aortography, aortic regurgitation is detected when contrast leaks from the aorta backward through the closed aortic valve into the left ventricle. During ventriculography, mitral regurgitation is detected when contrast leaks from the left ventricle backward through the closed mitral valve into the left atrium. Cath pressure tracings are acquired from the chambers proximal and distal to the regurgitant valve. Regurgitation creates a volume overload pattern that can lead to a pressure overload. Yeah, so increase in atrial pressure. How does chronic mitral regurgitation impact the heart? Great. Our options are left atrium compensates for the additional flow by dilating. Left atrial enlargement is beneficial and well tolerated. Left atrial pressure is not driven up, or all of the above. So there's going to be dilation. Which of the following is considered cath contraindication? Allergy to radiographic contrast, yeah. Cardiomyopathy, nope. Heart transplant, nope. Valvular heart disease, nope. So allergy, it looks like, is going to be oh man, there's so many. I'm going to have to go back through these on my own when I can really concentrate. Okay, contraindications. GI bleed, renal failure, acute stroke, allergy to radiographic contrast, anemia, severe hypertension, ventricular arrhythmia, and special precautions may be applied to some of these contraindications, making the cath possible. Okay, so we got that correct. Is that it, or do we have another question? I think we got a couple more. Yeah. Allergy. Identify potential risk associated with cardiac cath. All right, our risks are bleeding at the entry site, infection, injury to nerve or blood vessel, arrhythmia, tamponade, hypotension, reaction to contrast, kidney damage and or failure, stroke, myocardial infarction, or death. So, arrhythmia, hypotension, and tamponade. I don't think tamponade was on that list. Oh, it was. Okay, so we've got arrhythmia, tamponade, and hypotension. Okay, so all of the above. Some bleeding is expected at the entry site during calf procedures. Occasionally, there is more severe bleeding that needs special attention. That is true. Okay, hey, look at that. We got, you know, I was a little intimidated, but we got through this. I think we've still got one more part where we're going to be, yeah, this right here. We've still got a few more questions with these, and this is going to be the hard stuff. But yeah, this is pretty cool. We're knocking it out. I feel like this is the easy stuff, if I'm being honest. This is the easy stuff. Once I get this done, then we get into the hard stuff. Oh man, I might make myself another coffee. Maybe. Also, hello, hi. I haven't said hi. I look like a gremlin, and that's okay, because I'm doing homework, so. Okie dokie. Pressure tracings. Now this looks like a normal pressure tracing. Yeah. So, normal pressure tracing. Let's see here. Color and match the pressure. You know, I never color these things. It's always been optional. And if I'm being honest, I feel like coloring things is more of a distraction for me. But I can understand why they do it this way. But there we go. Okay. We've got aortic pressure is blue. Left atrial pressure and what is that? Capillary. This isn't the right one. Ah, there we go. This one's what we're looking at. Okay, so our blue. Our left ventricular pressure is green. And that's going to be right here. This is purple. I don't think I have purple sitting here. I have purple though. So we pink today. Left atrial pressure. Okay. Think about dyeing my hair today. Been red for like forever. And then I didn't dye it for like 2 years because I had a lot going on. I was a little distracted. Little case of the sads. A bit of a sad panda. Dyeing my hair did not seem important. And then I got into this program and I was like, oh, I need to make sure I look professional and nice or whatever. And the director of the program has the same color hair that I have been dyeing my hair since I was like 16. And I was like, well, now it looks weird. Now it looks weird because my hair is not that color, and it's been a couple of years since I had it that color, so it was all like, you know, it was all grown out. And my natural color is it's like a dark dark brown with like red and blonde highlights. It's pretty dynamic. Like, my natural hair color is not bad. I like it. I think it's nice. I've just been doing this for so long, and you know, I like it. It's what I'm used to or whatever. But I was like, well, I can't go back to the color that I've done before. And 2 other people dyed their hair the same color that I had been dyeing my hair for years, and I was like, well, now it looks weird. You know. So I was like, well, maybe I'll just do the thing where I'll do the darker color on the top and then the color that I normally do underneath, you know. But I've never done that before, and I've always dyed my own hair, so I don't know. We'll see. All right, I guess that's enough of a psychological break from this. We'll get back to it. Boop. Okay. So, aortic stenosis with aortic regurgitation. So we got to choose from these 4 pressure tracings. So aortic stenosis. So we're looking at, I think we're looking at this middle line. So if you look at the thing that's on the screen right now, the aortic pressure is the red, right? And the, let's see, what is that? The left ventricle is the blue. And that looks normal. So, with aortic stenosis, we're going to have a much higher left ventricle pressure. And our aortic pressure is going to be I think that's going to be normal too, but like late, like a late peaking. Okay. So I think that's going to be A. This is going to be our aortic stenosis. So late peaking aortic pressure and a much higher left ventricle pressure because the ventricle is squeezing, but that opening is too small to let all of the volume through. So the pressure increases in the proximal chamber. Okay, so, oh, but with aortic regurgitation, oh man. That's gonna look different too. Okay, so aortic stenosis with aortic regurgitation in the cath lab. We still have that high left ventricle pressure, and we still have that late peaking aortic pressure, but it looks like that pressure half time is longer. So it's a higher pressure half time for the aortic pressure. So if we do continuous wave Doppler on the left ventricular outflow tract, we're going to have stenosis on the bottom, right here, and that insufficiency on the top, and that's that pressure half time. It's going down very slowly, which I think that indicates that it's not as bad. Like if it drops really fast, I think that's worse. Like you don't want the roof to be too steep, I think. Oh, that was a question on the last test. So regurgitation of the mitral valve, you want it steep. But for the aortic valve, you want it flat. Yeah. Okay. Oh my God, this is hard. Okay. So, okay, so it's going to be C. Aortic stenosis with regurgitation or insufficiency is going to, it looks smoother than the other ones. Like it looks like way smoother, the lines do. Okay, so aortic stenosis without regurgitation or insufficiency. That's the choppy one. Okay. So that left ventricle pressure is still shoots up really high. The aortic pressure, it looks like it's less smooth. So, A. Elevated V wave. I'm assuming that's velocity. Elevated velocity wave. I'm missing something. Oh, there's the V wave. Okay, so what is it? Explain this V wave to me. I wonder if it's in the notes. An elevated V wave in the left atrial pressure tracing indicates mitral regurgitation. With acute mitral regurgitation, the left atrium does not have time to compensate for the additional flow, so the LAP increases. With the chronic mitral regurgitation, the left atrium compensates for the additional flow by dilating, known as left atrial enlargement or LAE. This is beneficial and usually well tolerated, therefore, the LAP is not driven up. Okay, but I don't think I understand the V wave. Is there a V wave in everything? Like, does the aorta have a V wave? Am I missing something super, super simple? Here we go. Peak velocity is the V wave. All of them have peak velocity. I mean, that would make them all V waves. That doesn't make any sense. I'm missing something. Google. Maybe you can explain it better. Cardiac pressure tracing V wave. The V wave is a pressure waveform seen during cardiac catheterization that represents the passive filling of an atrium against the closed valve during ventricular systole. Okay, so the V wave is the passive filling of an atrium. Closed valves during ventricular systole. So when the ventricles are squeezing the blood out into the aorta or into the pulmonary arteries, the V wave is the IVC filling the right atrium, and the pulmonary veins filling the left atrium. Passive filling, that is the V wave. Central venous pressure. Elevated V wave is increased blood volume or tricuspid regurgitation, which tracks with what we're looking at. Cool. Okay. All of these pressure tracings are going to be on the test. So I think what I'm going to have to do is make some flashcards and just memorize what they look like. So, all right. Let's see if we can get this done. Elevated V wave is elevated pressure and passive filling of the atria. So let's see where that is represented. Here. So this is our left atrial pressure during mitral regurgitation, and it is elevated, and it should be down here because the atria should not have high pressures. They are all about passive gravity, which is why when people have heart issues, they need to sit up more often because gravity does more work for them. So if the pressure is elevated in the atria, that's going to cause backup. So it's going to cause pulmonary not embolism. I mean, I guess it could, but retention of fluid. I'm having a brain spasm. Edema, pulmonary edema. So this will cause pulmonary edema. It'll cause systemic edema if it's tricuspid regurgitation. So elevated V wave is going to be D. Okay. Left ventricular systolic pressure is elevated and much greater than the aortic systolic pressure, creating a transvalvular systolic gradient across the atrial valve, the aortic valve without aortic regurgitation. Oh, that's a little complicated. Okay, so left ventricular systolic pressure is elevated. So that's going to be any of these. It's going to be any of these four. Okay. Much greater than the aorta systolic pressure. Okay, so this S wave right here, this is mitral regurgitation, so let's see here. This is the aortic pressure. Okay, but it's without aortic regurgitation, so it's one of these two. Transvalvular systolic gradient across the aortic valve. I feel like it's B just because we haven't seen that one yet. That's mitral regurgitation though, so it's probably A. Left ventricular systolic pressure is greater. It's elevated and greater than the aortic systolic pressure. Okay, so this is the gradient. Decrease in the end diastolic aortic pressure and an increase in the end diastolic left ventricular pressure as the aortic regurgitation leaves the aorta. But there's no regurgitation, so systolic left ventricular pressure is elevated and greater than systolic aortic pressure, creating a transvalvular systolic gradient across the AV. Okay. Hey, look at that. So it is A. Okay. Mean left atrial pressure is elevated. Okay. So that's going to be A. Or D. No. Well, let's finish reading it. Mean left atrial pressure is elevated and greater than left ventricular diastolic pressure, creating transvalvular diastolic gradient across the mitral valve. That's probably going to be D because that's our mitral regurgitation right there. Mean left atrial pressure is elevated and greater than the left ventricular diastolic pressure. So that filling is going to be funky. I think that's right. Starting to understand some things. Not well, but a little bit. Okay. let's read our description here. It'll probably say it word for word for us. An elevated V wave in the left atrial pressure tracing indicates mitral regurgitation. Okay. But all of them have an elevated left atrial pressure. This one is the aortic pressure, right? Yeah, okay. Okay. So the elevated left atrial pressure. Oh, that's funky. So we're gonna have to memorize the patterns in order to know what these lines indicate if we're not told. I mean, I could go in and label them, but I think this is probably better for getting my brain to remember it. Okay, so with acute mitral regurgitation, the left atrium doesn't have time to compensate for the additional flow, so the left atrial pressure increases. With chronic mitral regurgitation, the left atrium compensates for the additional flow by dilating, known as left atrial enlargement. This is beneficial, usually well tolerated. Therefore, the LAP is not driven up. Okay. And all these others, the LAP is over 200. But not our mitral regurgitation, because the left atrium is compensating. All right, D. Okay, so mitral regurgitation, that's also going to be D. And on button B is our mitral stenosis, because we haven't picked that one for anything so far. There we go. Yep, that's our mitral stenosis. The mean transvalvular gradient across the mitral valve is calculated. So this is our left atrial pressure, and this is our left ventricular pressure. Okay. All right. That's our homework for 1:30. Sweet. So cute. Okay. I guess we'll put this in so we get credit for it. What time is it? Let's see. I can't remember if I need to be somewhere at 1:30. I don't remember. I have plenty to do today. So if I don't need to be somewhere at 1:30, that would be great. Not that I don't love the people that are involved. Okay. You know, it just occurred to me that I didn't actually announce to anybody that I was going to be streaming. I appreciate you and I see you. So yeah, thanks. Let's see here. Puns. Ba-bum. Somebody mentioned something about whether or not we're meeting up today for D&D, and I don't remember. Don't remember at all. Oh. Two weeks. I thought it was today, though. I had no freaking clue. It looks like people are not meeting up today because there was confusion. It looks like people are wanting to meet up next week. So I'm going to be hanging out doing homework. So, but I am totally fine with doing more homework because I have a... Okay. I guess I'll make an announcement that I'm streaming for the people who are unaware. Okie dokie. Okay, so I made a little announcement. So now people know. I think I want to get some water before I put this in. We get to go over all this fun stuff again. Aren't you excited? I'm excited. Okay. All right, I'm gonna grab a drink real quick and I will be right back. Look how quick I was. Okay. We are on a roll here. Okay, so during the cath procedure, the cardiologist inserts a catheter into the patient's artery or vein, and then the catheter is threaded into the heart. That is true. What's the most popular approach for left heart cath? That is percutaneous femoral artery. Choose the catheter frequency utilized for left heart cath via femoral artery. That is the pigtail catheter. Choose the catheter frequently utilized for right heart cath via femoral vein. Swan-Ganz catheter. What procedure involves passing the catheter from the right atrium through the interatrial septum into the left atrium? I think that is transseptal procedure. Yep. Valvular heart disease is an indication for cardiac cath. I think that is true. Today, most labs store digital computerized images known as SIN or Cine. I mean, they have them, but most aren't utilized, so I'm going to say false. Because most of the time they use the Cineless is what that's called. Fluoroscopy is an X-ray technique with a screen that provides immediate visualization inside the body. That's true. Okay, and this one, oxygen saturation, that is not accurate. Cardiac output can be calculated via the indicator dilution technique, thermomodulation method, Flick method, or angiographic technique. So that is false because it's not oxygen saturation, it's cardiac output. The pressure distal to the pulmonary capillary wedge is an approximate left atrial pressure recorded when the balloon deflated equals the pulmonary artery pressure. Choose the right heart cath intervention. Let's see if I can remember it. The right heart cath intervention, pulmonary. Okay, so the oxygen saturation isn't right. Angiography is adding something. Pulmonary capillary wedge pressure. I think that's what it is. Oh, it's all of them. All of these are things they do in the right heart. Okay. That's what is meant. Okay. Pulmonary angiography is used to diagnose pulmonary embolism. That's true. During the cath procedure, one can detect a shunt, calculate shunt size, and sometimes treat with a patch. Which of the following does the left ventricular angiogram assess? I'm thinking left ventricle function. Yep. What intervention involves injecting a radiocontrast agent directly into structures so it becomes temporarily visible on X-ray? Angiogram? Yep. Left ventricular ejection fraction is computed in the cath lab via the area length method or eyeballing it. True. What happens when plaque buildup inside the lumen, coronary artery occlusion. Coronary angiogram is one of the most popular studies. True. Okay. That's weird. Just told me my camera was on as a lab. It's true. Okay, good. Choose the intervention that utilizes a catheter equipped with a balloon that inflates and presses the plaque against the wall of the coronary artery. Stenting, coronary inflation, percutaneous transluminal coronary angioplasty. I bet it's that one. Yep. After the plaque is pressed against the wall of the artery, what is inserted? That is a stent. S-T-E-N-T. Stent. Choose the intervention that utilizes the catheter equipped with a cutting device, whirling blade, or laser beam that removes the plaque. Atherectomy. Laser ablation sounds specific to the laser, so yep. Intravascular ultrasound utilizes coronary artery catheter equipped with a miniature ultrasound transducer that acquires images of the coronary lumina walls, outlines the blood flow through the lumina. True. Cath pressure tracings are acquired from the chambers and peak pressures are compared, known as the peak-to-peak, I believe. Pretty sure. Mean pressure gradient derived in the echo lab correlates best with the cath mean pressure gradient. True. Mean pressure gradient provides an average derived from all of the velocities within the flow between the two chambers. True. Doppler echo provides peak instantaneous pressure gradient for peak gradient between two chambers at the same instant in the cardiac cycle. True. Cath determines present severity and etiology of regurgitant valve. True. Oh, goodness. My brain is tired. What procedure identifies aortic regurgitation when contrast leaks from the aorta back into the left ventricle? So you're going to, if you're looking at regurgitate, you're going to put the contrast into the distal chamber, so that's going to be the aorta. So aortography, probably. Yep. With acute mitral regurgitation, the left atrium does not have time to compensate for the additional flow. What is the result? That is going to be an increase in left atrial pressure. How does chronic mitral regurgitation impact the heart? Left atrium compensates for additional flow by dilating. Left atrial enlargement is beneficial and well tolerated. Left atrial pressure is not driven up. So left atrium compensates for the additional flow by dilating. I remember the book said that left atrial enlargement is beneficial and well tolerated, but left atrial pressure is driven up, isn't it? Did I get that one wrong when I was doing it? I think I understand it better now than when I answered that question, so let's go back and take a look. Chronic mitral regurgitation impact. So that is going to be... Okay, that's aortic. There we go. Elevated V wave in the left atrial pressure tracing increase indicates mitral regurgitation. I think I'm going to close that because I think I keep getting notifications because of that. Okay. So, with chronic mitral regurgitation, the left atrium compensates for the additional flow by dilating, enlarging. This is beneficial and usually well tolerated. Therefore, the left atrial pressure is not driven up. Okay. Well, I got that one wrong when I wrote it out, but since we have learned while we've been doing the homework, that one is one that we will get right now. Which of the following is considered a cath contraindication? An allergy. Identify potential risk associated with cardiac cath. All of the above. And some bleeding is expected. True. Okay. Now we've got these. What is happening? Okay. So for this, we have left atrial pressure identification, left ventricular pressure identification, and aortic pressure identification. So I, with 3, is going to be aorta. Oh, these things mix up so crazy. I hate it. H, LVP. H is 2. Okay, so the left ventricular pressure is 2. And 1 is the left atrial pressure, which is G. Golly. It's mean. It's mean how crazy these identifiers are. It's difficult for me to explain, and I don't want to spend too much time complaining while I'm trying to be, studying and concentrating, but the pictures in book the waveforms are identified with letters. And you associate that with the name of the waveform. And on the homework on the website, the waves are identified with numbers that you're supposed to associate, but nothing is in any sort of order, and it is incredibly confusing transposing things. Now, if you know the waveforms, super easy compared to this, but still difficult because everything's all mixed up. Anyway, I'll stop complaining now. Once I learn this stuff, it'll be a lot easier. But like the thing is, I know the wall segments. I know the arteries where those are, but it's still possible for me to get it wrong because of how it's organized is very confusing. Anyway, I'll stop complaining now. Okay. After we get these done, we're done with this homework, and I think we'll take a break and then come back later. Because I gotta eat at some point. So. Okay, so we are looking at what tracing is the mitral regurgitation. And that's going to be D. The mean left atrial pressure is elevated and greater than the left ventricular diastolic pressure, creating a transvascular diastolic gradient across the mitral valve. Okay, so that's going to be D as well. Because that's describing the pressures involved in mitral regurgitation. Okay, so the elevated V wave is going to be C. Nope, that's D as well. Okay. Well, that, is that right? It doesn't. So in stenosis, aortic stenosis, and aortic regurgitation, it looks like the V wave is elevated, but I don't think that that's what is on here, and I don't think I understand why that's the case. I think if I go through and read it again, maybe something will click. So the V wave is the left atrial pressure. And if we're looking at, so I understand why now. The reason why it's not A or B, the reason why it's not A or B, even though these waves are higher, is because these are aortic pressure. This isn't a V wave because it's not a left atrial pressure. So I understand now why that is the way it is, because in B, you have the left atrial pressure is bouncing around between 10 millimeters of mercury and 20 millimeters of mercury, and then goes back down to like 8 or whatever. But in regurgitation, it's all the way up past 50 millimeters of mercury. But that's the only one that's actually got a V wave, because that's the left atrial pressure, not the aortic pressure. I understand. Okay, so it is D. So left ventricular systolic pressure is elevated and much greater than the aortic systolic pressure, creating a transvascular systolic gradient across the AOV without aortic regurgitation. So that's going to be aortic stenosis, and that is going to be C, I think. No, A. Okay. A. Okay, aortic stenosis with aortic regurgitation is C, and it is smooth. Aortic stenosis with regurgitation has a smooth aortic wave. Mitral stenosis is B. And that's got that low wiggly S wave. Aortic stenosis without aortic regurgitation is A. All right, let's see what I got. 97.7. What did I get wrong? Ugh. Mean. Oh, it's B. Mean left atrial pressure is, I should have checked that one. B. Okay, cool. I'm fine with this. I got a 90 on the last exam. I only missed 1 on this homework, so that's cool. Let's see. What's my grade in the class? Ugh. The first quiz was really hard. I forgot about that. I'm getting a 90 in the class. That's fine. I'm okay with that. It's a B. It's a B, but it's a decently high B. It's a fine B. Okay. Hi. Let's see if we got some light. Hello. Okay, so we got homework done. We got the book homework done for 2 classes. I've still got a rough draft for the short story that I have to write describing the Epstein anomaly, which honestly that shouldn't take too long, just because I've already written most of it. Let's see. Let's check, see what else we have to do. Oh, God. I have to do a self-assessment for the lab still, for my last, for the tricuspid valve assessment. I have to go back in and do a self-grading thing for that. And the last time I did that, that took, I want to say probably an hour. Let's see if she graded any of it so far. She did. What did I get? I don't think that one's... Is that right? It doesn't look right. Really? Oh, okay. I was gonna say. I was like, I thought I got an 82 on the last one. And I did. But this one is not graded yet. I bet $1 she's gonna wait until after we self-assess. Okay. That one's gonna be really hard to go through and self-assess. Really? There's only 69 pictures in here. That's surprising. I got through it like super fast though, compared to what I thought I was gonna get through it, but I mean, this isn't like, I don't think I should go through this showing the pictures though. It wasn't like, so the people that volunteer that come in, this isn't like a doctor-patient like confidentiality thing. There's no HIPAA involved here, but I feel like the ethical thing to do is to treat it in that way. So legally speaking, there isn't really HIPAA protections here. Ethically speaking, I feel like HIPAA should be followed in these circumstances. Like, especially if you don't ask the person. Like, you shouldn't be showing people's guts to, like, other people. This seems, like, way too bright. Like, I don't understand how it's this bright. I need to ask her about that, because this seems, like, crazy bright compared to what I was actually looking at. Yeah, this is like crazy bright. I don't feel like any of this is accurate gain-wise. Yeah, all of this is crazy, crazy bright. Maybe this is why I'm getting so many points off for gain, because the translation from the machine to the computer when you're looking at it later is not accurate. Yeah, that is insane. She was literally working with me while I was doing it. If there was a problem with the game like this while we were working on it, she would have said something. Sorry. Anyway, none of this has to do with anything. You can't see what I'm talking about. Super sorry for that. Anyway, I'm gonna get off of here and get something to eat and call my friend back, because they have been blowing up my phone and I'm not really sure. Okay. God. Okay. Yeah, I gotta deal with that. Okay. Thank you for coming by. I'm very happy to have you here. I'm gonna go complain loudly to some people and ask some very important questions of others. Eat some food, and then I will be back. I hope if I don't see you again, everybody make sure you drink a full